Doctors, we are live. You can start the session.
Okay. Good morning, friends. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the TNOA, I have great pleasure welcoming you all for this 12th TNOA Connect series in association with Arasan Eye Hospital, E Road. As you all know, the theme for this year is Tamil Nadu Smiling and TNOA Shining. And we are doing that for the past almost 10 months now, since September, since I took over as the president of the TNOA. This Connect series has become a very popular series, which we usually have it on the last Sunday of every month. And what we are trying to do in this Connect series is to connect all the major institutions in Tamil Nadu. As you all know, Tamil Nadu is the mecca of ophthalmic education. And most of the major institutes are here, starting from Aravind, the Shankar Netralaya, the Eye Foundation, Agarwal, Arasan Eye Hospital, and so many other hospitals which are in the length and breadth of the state, providing quality eye care, and not only quality eye care, but also quality ophthalmic education to the postgraduates, residents, and ophthalmologists across the country as well. And today I have great pleasure in getting associated with Dr. Pannir Selvam, who has been an iconic figure as far as Tamil Nadu ophthalmology is concerned. And his institution, the Arasan Eye Hospital, is probably the supreme power as far as manual small incision cataract surgery is concerned in this part of the world. And it is only appropriate that Arasan Eye Hospital is the connecting institute for this major webinar today. Friends, TNOA has been very active in the academic front for the past 10 months. Thanks to the support which I have received from all the office bearers of TNOA. And in last evening also, we had a fantastic program on cornea, the TNOA ARC Masterclass, which was actually on corneal infections and corneal inflammations by Radhika Natarajan and her group. And it was really a fantastic class, a masterclass, truly a masterclass. And last week we had a masterclass on uveitis by Dr. J. Biswas, which was actually an international masterclass similar to what you are having today. And it was also very good. I've been receiving very good feedback from all the ophthalmologists across the country that all the academic activities at TNOA are well appreciated by one and all, very useful to all the practicing ophthalmologists, postgraduates, residents, and fellows across the country as well. I have to thank Dr. Nivian, Dr. Pannir Selvam, and Dr. Manoj Vasudevan, the joint treasurer of TNOA, Dr. Manoj Vasudevan, who is coordinating this webinar very successfully. Not only this webinar, so many webinars Manoj was there, and I'm very thankful to you, Dr. Manoj, for the meticulous way in which he plans everything. He starts his work even 4 months prior to the date of the webinar, and that is something which is incredible. And of course, Nivian, I don't have to thank Nivian. He is my younger brother, and he is the star of the ophthalmology in this part of the world. Pannir Selvam, my pranams to you, my salutations to you for the work you are doing, for the wonderful work you are doing, and the motivation and inspiration you give all of us. You are a role model for all of us. I am sure your inputs in this webinar will take us a long way as far as manual small incision cataract surgery is concerned. I also welcome the speakers from abroad, from Ethiopia, and it's a real pleasure to have them here. And also the national faculty as well for this wonderful webinar. I request Dr. Amulya Sahu is also joined. Okay.
Sure.
Welcome, Dr. Amulya Sahu. He is the main force as far as the International Association of the Manual Small Incision Cataract Surgery is concerned. He is the main force behind. I know Amulya Sahu and Boramani are the people. They are like Virat Kohli and Rohit Sharma, and they work. They have taken small incision cataract surgery to the international map. thanks to them, I'm very glad that Dr. Sahu is here with us. And I request our President-elect, Dr. Ramakrishnan, who is a source of inspiration for all of us, to say a few words.
Thank you very much. And respected President, Dr. Mohan Rajan, and Secretary, Dr. Madhavan, and Treasurer, Dr. Loganathan, and other office bearers of TNOA. And
Sir, your voice is breaking, sir.
Okay. Clear now? It's clear?
Yes, sir.
And it's okay now? It's clear?
Yes, sir.
Okay. Yeah. And, just a minute. Vivek.
இல்ல பக்கத்துல விவேக் ஆஃப் பண்ணீங்கன்னா தான் உங்களுக்கு இல்லைன்னா ஜாம் ஆகும்.
Yes.
இல்லைன்னா ஜாம் ஆகும்.
Yeah.
He has to go to different rooms, sir. That will be
Okay. Go to different. Yeah. Okay.
Ask him to go to a different city, neighboring city.
Okay. Okay, thank you. Okay, good morning to all. And of course, cataract surgery is the bread and butter of all of us. And of course, even though the phacoemulsification is the procedure of choice, in countries like India, where the magnitude of cataract blindness is so high, SICS plays a major role in managing the cataract in our country, and not only here, and also in most of the developing countries also. And in that way, SICS has gained a lot of popularity in our country, and there are so much of development also in the technique and the type of IOL and astigmatism free, and so many things have come up with the SICS surgery. So it's important to update our knowledge of SICS. And of course, I have to thank our President, Dr. Mohan Rajan, for done this academic work for the past nearly 1 year without any break, with so many webinars and other symposiums, and also the Walk the Series program for the non-stop for the last 1 year. I'm really very, very thankful and congratulate our President. And next, I have to congratulate and thank the Director of Arasan Eye Hospital, my dear friend, Dr. Paneer Selvam, for organizing this webinar on SICS, and also the coordinator, Dr. Manoj and Nivian, for wonderfully arranging the speaker. The faculty are wonderful faculty, including the national SICS leader, Dr. Amulya Sahu, and also Dr. Venkatesh, and all the other people are wonderful. They are doing this SICS for more than 3 decades, and quite well with the all the techniques and the complications and all these things, which is very much useful for the dissemination of knowledge, is very much useful for the younger generation, because as I mentioned, this is the basic of all the ophthalmic surgery. So in that way, SICS is one of the important surgical procedure where all the ophthalmologists, including the residents and fellows, they have to have a thorough knowledge. In that way, the topic selected in this webinar is a wonderful topic, and the speakers are also very, very well experienced in this field. So definitely it will be a very big boon for all of us. So as others, I am also eagerly waiting to listen to the talks and the discussion by all the esteemed panel members. Thank you very much.
Thank you, sir. I think we have to give it to Arvind Eye Hospital. Welcome, Dr. Venkatesh here, Arvind Eye Hospital, for the putting this the SICS on the global map, I would say. And you are the forerunners as far as SICS is concerned, way back in the 90s. And we know how SICS has grown leaps and forwards, mainly because of the push given by the Arvind group. And we go on to our dynamic secretary, Dr. Madhavan, who's doing a wonderful job. And Dr. Madhavan to say a few words.
Thank you, dear President. Dr. Mohan Rajan, President-elect Dr. R.K. sir, and our past President, Dr. VPS sir, and Dr. Manoj, and all the elite panelists, moderator, and speakers of the day, and the members of TNOA who are glued up to Facebook and YouTube for today's event. Very pleasant good morning to you all. And at the onset, it's a great pride and privilege that today we are in coordination with Arasan Eye Hospital of Erode. Being from Erode, it gives me great pride that we have Dr. V. Paneerselvam, who has put Erode both in national and international ophthalmic map to say, and it's a great pride that TNOA is organizing such an event with Arasan Eye Hospital, Dr. Paneerselvam. A few words about him. He's a unique personality and a unique person who has received both our most celebrated Dr. Joseph Nanadikam Award and Dr. Venkatasamy Community Ophthalmology Award, a unique person that he has received both the Origin Awards from TNOA. Thank you, sir, for today's participation. And a few association-related mentions. So next month, we have our 69th TNOA conference at Coimbatore Kodisa Hall, and which I hope will be a mask-free event after 2 years of hiatus. And I request all our members to participate in full strength and make it a grand success. And also, our 4 years of being in association comes to end in August, and we are looking forward to a new crop of office bearers to lead us forward. And in this regard, we have our unique and first time historic online elections slated later in the month of July. And the process of updating our membership details is an ongoing process. And I request all our members to update the data so that we have a smooth and comfortable election process ahead. So thank you, and looking forward to a wonderful webinar today. Thank you, sir.
Thank you, Madhavan. And as you rightly said, Paneerselvam is going to be the next Walk the Talk luminary for us in the month of July. And we are going to end with that. And we are always reserved the best for the last. And we are looking forward to a great Walk the Talk session with Dr. Paneerselvam, the icon from Tamil Nadu Ophthalmic Association. And over to Dr. Manoj Vasudevan, Dr. Nivian for this webinar. We are looking forward to a great webinar and a very useful session as well. Manoj.
Thank you, sir. Thank you very much. Good morning, one and all. Welcome to this program again. I have this great pleasure and honor to introduce today's panelist for this session. First, Dr. Mohan Rajan sir, who is our beloved dynamic president of Tamil Nadu Ophthalmic Association, is a founder chairman of the Rajan Eye Care, Chennai, Tamil Nadu, India. Secondly, we have Dr. Amulya Sahu, who is a very prolific MSICS surgery, and he is a founder chairman for the Society of Manual Small Incision Cataract Surgery, and he is the medical director of Kamal Nethralaya Eye Care Center in Mumbai. Welcome, sir. Thirdly, we have Dr. Venkatesh sir. He is the Chief Medical Officer of Aravind Eye Care System, Pondicherry. Very prolific and popular surgeon of our country as well as globally. And he is also my teacher. Welcome, sir. And finally, we have our international panelist, Dr. Warkiyahu. Welcome, sir. He is the founder chairman of Roha Eye Care Specialized Eye Care Center in Ethiopia, working very tirelessly in the African continent for the last 25 years. And he has been a very popular and trying to popularize MSICS surgery all around the world. Welcome, sir. So now I request Dr. Nivian to introduce the speaker and start the session.
Thank you, Dr. Manoj. I think without any further delay, because we have a long list of speakers, I think we'll go ahead to the first speaker. I think Dr. Paneerselvam sir, who's been a good friend of Dr. Pradeep Mohanta sir, who needs no introduction. I think sir will be introducing Pradeep sir, and then we will start off with the first talk.
Welcome, Pradeep.
Pannisalam sir.
Right, Patu, right, Patu.
Sir, you have to unmute sir. Pannisalam sir. Yeah.
Good morning, all of you. I thank Dr. Mohan Rajan for giving us the opportunity to conduct this webinar on behalf of TNOA. Thank you, Mohan, for this great honor. I thank Dr. Nivian and Dr. Manoj for organizing such wonderful speakers for this. Their help was immense in conducting this program. And we have a galaxy of speakers and the panelists, as you know. And I warmly welcome my good friend, Dr. Pradeep, to give the first speech on the art of wound construction. Dr. Pradeep Mohanta graduated from, did his DO in Jipmer, Pondicherry, then he did his MS in PGA Chandigarh, did his VR fellowship in Shankar Nethralaya, started his practice 100 kilometers from Calcutta, Netra Jyoti Eye Hospital from 1994. He's a prolific surgeon, excellent teacher, passionate very much about it. And he has got a YouTube channel which has got 29,000 followers, second highest followers. And he has released around 1,900 surgical videos on SICS, phaco and all. And we are very happy to have him here. And over to you, Pradeep, for your talk. Thank you.
Welcome, Pradeep. Pradeep, it's a great honor for the TNOA to have you.
Thank you. Thank you all. Thank you, Mohan. Thank you, Pannisalam, Anna. Let me share my screen. Am I audible?
Yeah. Yes, yes.
Yeah. So this is, I am actually a ECC surgeon who shifted to phaco, and then I learned SICS just to teach the residents. So my SICS is very basic. So my presentation is targeted to the residents and new surgeons who are learning cataract surgery. So the eye, for wound construction, the eyelid margins should be nicely covered by plastic drape. Eyelashes should not project out. If it projects out, we have to trim it very nicely. Povidone iodine 5% drops are instilled and ocular surface is nicely irrigated with ringalactate or BSS. This is the basic steps for wound construction. And now conjunctival peritomy is done. Before that, the superior rectus brittle suture is applied. The eyeball is turned downward by applying a muscle hook to when the inferior fornix. The superior rectus tendon is held nicely with a holding forceps, and a thick nylon suture is passed under the superior rectus tendon. The needle is pulled out and the superior rectus tendon is fixed. We get a lot of space to work on, get the eyeball, very stable eyeball to do peritomy and sclerocorneal tunnel. So this is a very important step, putting the superior rectus brittle suture for beginners. And now 2 clock hours of conjunctival peritomy is enough for most of the cases. 2 clock hours of conjunctival peritomy from 11 o'clock to 1 o'clock for superior incision, from 8 o'clock to 10 o'clock for temporal incision in the right eye, and 3 o'clock to 2 o'clock to 4 o'clock in the left eye is enough. This is a superior incision from 11 o'clock to 1 o'clock. And conjunctival peritomy is done. In this case, tenons and conjunctiva are taken together. We must do a very mild and gentle bipolar wet field cautery. And conjunctiva, the ocular surface, the sclera should not contract by too much cautery. Only And at this time, the conjunctival margin should be protected by a Johnson bar. If we touch the conjunctival margin, it will shrink. So that should not be done. And now, how deep to go for this? We have learned it through experience. We have gone through and through the sclera. And this is a 50 number Bart Parker blade. This is very tough. How much force should be applied to make this initial incision? So we have come up with an idea, a new idea, which we will share at the end of this presentation. Now I start the sclerocorneal tunnel, usually at the central part, go about 1.5 to 2 millimeter into clear cornea, sweep backward and to the left for the left side of the tunnel, go a little anteriorly and lateralward on the sides so that inner incision becomes little larger than the outer incision. We must remember the contour of the eyeball at this time. If we don't remember the contour, we must remember that the ocular surface is not flat. It is curved and we have to place the blade accordingly. A side port about 1.8 to 1.9 millimeter has to be made so that we get a wound through which a Simcoe cannula can go in. Now, after rhexis, injecting some visco, we open the wound. Till now, the sclerocorneal tunnel is blind. Now we go to the anterior extreme of the tunnel and then go downward, and we cut when we go forward. And thus we get a nice corneal valve and we get a self-sealing wound. In hypermature Morgangian cataracts, the eyeball is little congested. There is bleeding is more. So in these cases, we have to take care. We may tend to do a lot of cautery in such cases, but that should not be done. Very mild, gentle cautery should be done. In this case, I'm taking only the conjunctiva first. The tenons capsule is very thick. Now the tenons is being dissected out from the sclera. So when the tenons is very thick and you cannot take the tenons along with conjunctiva, you have to dissect the tenons nicely so that the scleral surface is exposed. And then the scleral surface is nicely cauterized. And this is the wound. This is almost a straight wound. At the center, it is about 1.5 millimeter away from the limbus, and on either side is about 2.5 to 3 millimeter away from the limbus. And beginners should not go too much into the sclera, then dissection becomes difficult. It can be about 1.5 to 2 millimeter away from the limbus, but not more than that. Beginners are learning this surgery. Their aim is to learn this surgery well and then think about how to correct the astigmatism. And now, this is how we do the tunnel, the sclerocorneal tunnel. Must remember the contour of the eyeball and place the blade in a slant way when we go to either side. Very nice corneal valve should be achieved to get a self-sealing wound. Otherwise, we have always the option of putting sutures.
Nodi,
Yes. Hello. Mohan, you're talking something?
I'm sorry.
Okay. Then in this case, the anticapsule is punctured and we see the milky fluid comes out. And I thought it will be difficult to do rhexis with needle. So I opened the tunnel and when the tunnel is open from one end to the other end, and we can do rhexis with utrata forceps, but we must take care that the antechamber should be deep enough. We can inject visco again and again to keep the antechamber deep while we do the capsulorhexis. In hypermature Morgagnian cataract, it is difficult to do rhexis with a needle. We get more control in such cases with a utrata forceps. Inject visco nicely. Take the utrata forceps, hold the capsular tag, and do capsulorhexis. And this is a very nice technique for beginners for very hard cataracts, for huge nucleus, thick black nucleus. I call this double SICS. This is one SICS wound. This is another SICS wound. They join at the middle at around 12 o'clock. And we can manage this cases just putting on suture where the two SICS wound meet here at the apex. This is a V-shaped incision. Actually, two SICS wounds meet each other at the center, and we need to put only one suture. Each SICS wound in this case is about 5 millimeter in length. And now this is one. We come to the apex. Then we go to the other side. Must maintain the plane. From one end to the other end, you must maintain the same plane. So we have got a wound which is about 10 millimeter or 11 millimeter wide. And we can manage this case just by one suture. In our time, in ECC time, we would have put about 10 to 11 sutures in such cases. But this idea, just two SICS wound meet at each other, and we just need to put one suture where the two SICS wounds meet. Stain the capsule, inject visco. In such cases, I usually enter the antechamber now on the right side, go to the anti-extreme and make this much, about a 3.5 millimeter wound. And through this, I can do rhexis nicely. After rhexis, inject visco. And now we open the wound from one side to the other side. Inject visco to fill up the antechamber. Make the intraocular pressure high. And now use the keratome to open the tunnel. Go cut the corneal tissue when we go forward. And with such wound, the nucleus comes so nicely. Just see. After prolapsing the nucleus, this is visco expression of this huge black nucleus. In this case, a multi-piece intraocular lens was implanted. And then we just put one suture where the two SICS wound meet, and one more suture to oppose the conjunctiva. This is a releasable suture to oppose the conjunctiva on the right side of the wound. Beginners must remember that it's not necessary to think that we have to do small incision, very small incision. We have to protect the corneal endothelium. We have to give vision to the patient. This must be the first thinking to beginners. When they become expert, they can think of, we can go for small incisions. After injecting subconjunctival injection of dexamethasone and gentamicin, the conjunctiva comes forward. Then we put this releasable suture, just 3 loops, and cut the sutures. And see how nicely the wound is opposed. And just by one suture, the patient does very well. Now we come up with a brilliant idea for beginners. We sat in the last AIOC. We sat together, myself, Dr. Paneerselvam Anna, and a representative of Appasamy Associates, Mr. Ravi. We brainstormed and came up with this idea of guarded incision blades. Different guards, 300 micron, 350 micron, 400 micron, and 450 micron. For myopic eyes where the sclera is thin, we can use 300 micron, and for other cases, 350 or 400 micron. 450 micron incision may not be necessary at all. So this is a brilliant idea. We can just press on the sclera hard, but it will not go beyond 350 micron. See, pressing hard onto the sclera, and the incision is going to a certain depth. So this is a nice incision blade which we can give to the hands of the beginners, and they can make incisions, and it is of certain depth from one side to the other side. And now the crescent blade comes, the regular one, and we do make the sclerocorneal tunnel as usual. Since myself, Mohanta, Paneerselvam Anna, and Appasamy Associates devised this, I have named this incision MP guarded incision blade, and it is available with Appasamy Associates. All the presenters and all those who are watching this video can ask Appasamy Associates to ask for these guarded incision blades. And we open the tunnel as usual. I hope this blade will be very useful in the hands of the beginners, and it will be a safe surgery. There will not be through and through cut. The anterior flap will not be neither thin. Thank you very much for having me here. Thank you, Paneerselvam Anna, Mohan Rajan, and all the panelists and all of you for having me here. Thank you very much.
Thank you, Pradeep. Thank
you. Can I comment on this?
Yeah, please.
Sure.
Yeah, Pradeep, you are a wonderful surgeon, and you have shown.
Stop sharing the screen.
Can you hear me?
Sure.
Yes, sir.
Please stop sharing the screen. Yeah.
Okay. This is a wonderful. You are a very good experienced surgeon. You have shown some basic steps which are every beginner should learn. But a few points I want to bring to notice: the superior rectus, you should not be taught to the coming generation, because we have seen there is no need for it. And those who are teaching, they should bypass this superior rectus thing.
Okay.
Second point I want to bring to the notice of those who are thinking, please give up this flat side port thing. You know, you try to use MBR there, because in the flat wound, if you are putting a round thing, there is a descent separation will be there. So MBR blade will be a better preference there. And about the two SICS, what is the extra advantage, and how many case studies you have done, and what kind of astigmatism you are creating? Now the whole focus is we have taken SICS to a next level. I'm doing 2 mm with all kind of lens implants with and excellent results we have produced. You both from my publication in IJO, you will realize that the next thing is that we are competing with the best in the phaco surgeons in the world.
Yes, yeah, yes.
I have been invited to AO to talk on advanced.
My presentation is targeted to the beginners, not to experts.
I salute you. Your experience is good.
I am not teaching 2 mm incisions. My aim is not that at all. My aim is to teach 7 mm incision to the beginners. Let them do it for 1 year. Then they go for 2 mm incision. No, sir. I don't agree with you. I don't agree with you.
You are not here to agree with me. I'm sharing my experience. And you are
Yes,
sharing
fine,
your
fine.
experience. We
You
are
can
not here-
teach.
No two
you-
person agrees, but the better
Better
thing will
thing you
prevail.
teach when they become expert in basic things, not when
I think
they are
you
learning.
start with let them do 6 or 7 millimeter, and subsequently when they are becoming more experienced,
Yes,
they
yes,
can go to migrate to 2 millimeters. Sir.
yes,
Yeah,
yes.
That is what he is trying to say.
We want
Yes,
when you are teaching the big, because you are an outstanding surgeon, people look up to you. When you tell something, people accept it. It is the gospel of truth.
Fine, fine. But I'll teach 7 millimeter incision to beginners, not 2 millimeter incisions.
2 millimeter will come much after. Now I'm talking to the what is the target, and you are starting in the
Yes,
right
target
way.
is fine, but initial, my presentation is targeted to the beginner and the surgeon who is going to learn cataract surgery.
Yeah.
Okay.
Okay. Both of you
Yes, sir.
spoken. Now, the next, anybody wants to comment on that?
Paneer, can I make a comment? I think Pradeep, hats off to you. Wonderful videos, very, very self-explanatory. The way you construct the wound. Only thing is, I'm a little concerned about that 1.8 millimeter the side port incision. Why do you want to make it 1 point? Because you need only the Rex. Why can't you do the Simcoe through the main port?
No, sir. For upper part, for cleaning the visco in the upper part, it is not good in the hands of the beginners to remove the cortex where the main incision is. You need a side port, and it doesn't matter if you make a large side port, even if it is 2 millimeter, it doesn't matter. If the side port is 3 hours away from the main incision, it will just reduce the astigmatism produced by the main incision. Any side port which is 90 degrees away from the main incision, it will reduce the astigmatism produced by the main incision.
Okay. Thank you, Dr. Pradeep.
Very nice, Pradeep.
Can I ask a question? Yes.
Yes.
Sandeep really is a wonderful presentation. Just one question: what is the advantage of this double SICS incision, and what are the situations you will do? And what I feel is when you do a double SICS, it will lose the basic property of self-sealing property of SICS. Am I correct, or can you explain?
No, sir. It doesn't. It's a SICS wound, and you're putting only one suture at the apex, and it doesn't produce astigmatism because the wound is nicely opposed by that on suture. And it is very easy if you make a large incision, the sides go so far away from the sclera. It's very tough for the beginner to manage such rock hard, huge nucleus. If you make 2 incisions, the incisions are nearer to the limbus, dissection is much less, and you just need one suture. That is the idea.
Pradeep, I just want to, because you are putting 2 5 millimeter, which is going to be 10 millimeter now.
Yes, yes.
Whereas these hard cataracts, we can actually manage with about 6 millimeter, if I'm right. 6
No. By 6 millimeter, you cannot manage a huge nucleus. You go to at least 8 millimeter or even 9 millimeter. There are black cataracts where you need so big incisions. Cannot manage.
The idea of having a 2 incision is to finally you put one suture. That's about what.
Yes.
It is not compromising on the self-sealing wound.
Yeah, that's what makes sense. Yeah.
And the whole idea is having a bigger external incision, and it is tied to one suture, which is much more stable than having a large incision, which will have the sagging effect. That's what the Pradeep is saying.
Right.
Okay. Very nice.
Thanks. I think we can time to move to the next speaker. We have 5 speakers. Thanks, Dr. Pradeep. Thank you very much.
Thank you, Pradeep, sir. I think next we have our international faculty. I'm happy and honored to welcome Dr. Jafar Kedir Abdullah. He's Assistant Professor of Ophthalmology and Consultant in Cornea and Anterior Segment Surgeries. He's also the head of the department of the Jimma University. So I'm very happy that they have accepted our invitation to be a part of this. So the initial talk is just going to be on about the situation of SICS in Ethiopia, so that we all have an understanding, and they also wanted to know how things are done in India. So this is just the beginning of something great. So basically the entire idea is to join and open a chapter in Ethiopia through MSICS. and with the same goal of inspiring the other doctors in Ethiopia to start doing SICS surgeries and to teach them that different techniques. And at the end of the day, the patient has to get the benefit. And that is what the whole entire idea is all about. So once again, I like to welcome Dr. Jaffer for his talk.
Thank you, Dr. Nivian, and the whole team too. I also thank my colleague, Dr. Volcayo, for informing me about this great group. So I will not go to the detail of MSICS here. I just give you an overview of the situation here in Ethiopia. Let me share my slides here. I hope you can hear me, right?
Yes, Jaffer, all good.
Okay. Yeah. Let's see an outline. I'll introduce you some background about Ethiopian situation, the history of cataract surgery and the ophthalmology in Ethiopia. And I will brief you a few things about the types of cataract surgery and the MSICS procedure here. So we are here in Ethiopia, the eastern part of Africa, where we have a population of like 110 million, around that. We have agriculture-based economy. We boast that we are homeland of coffee, and we think we are origin of mankind because the oldest human fossil is found in Ethiopia is Lucy. We are also rich in culture and history. We are known by long-distance runners too, but we are still in developing country category. Having said this, we have also the highest rate of blindness in the world. We don't have the very recent data, but the data some 10 years back shows we have the highest rate. Maybe the blindness rate is thought to be about 1.6%, is among the highest. And as usual, the commonest cause of blindness is cataract. Having the largest number of cataract, we have, on the contrary, we have poor cataract surgical rates. So among the 110 million, the cataract surgical rate per million is not more than 400 or 500 every year. So we have also the highest prevalence of glaucoma. Among that, we are in this category. And here is just some pictures. This is the Nile, one of the Nile Fall, the largest I think, river in the country and in Africa too. These are some pictures of Ethiopian situation. This is a typical rural area, and this is the capital city, Addis Ababa, and this is just one cultural center in my surroundings, Jimma University, and around that. Ophthalmology in Ethiopia has been maybe started some 20-30 years back, the modern one. Formal postgraduate ophthalmology residence training was started in 1980. And the first ophthalmologist is still alive in Ethiopia. He's called Paulos Kanaa. So early cataract surgery procedure was ICCE. There was no lens at that time. There was a phakic glass correction. So ECC plus PCIL was introduced in 1997 by foreign ophthalmologists through Fredor's Foundation. I think it's almost 50 years late. It's in the world. It was introduced by in 1949 by Ridley. But we got that after 50 years. And FECO was introduced in 2003 by international ophthalmologists visiting Ethiopia and Flying Eye Hospital by Orbis. The first trainee is named Dr. Jonas. He's still alive. But we got that 26 years after it was introduced in the world. I think it's by Kelman, I think, in 1967. And finally, SICS was introduced in the year 2004. The first training was still Dr. Jonas. He had training in Nepal. Yeah, on the contrary to the others, I think we learned SICS fast, just only 5 years after it has been started in the world in 1999 by Dr. Rohit of Nepal. So this is our situation. I hope now we are learning faster. This time, if there is a new technology, I hope we have in a few months or so. There are 300 primary eye care units and not more than 15 secondary eye care units in our country. Tertiary eye care centers with training are now 5. It has been one for many years. There are several private ophthalmic clinics. Now in Ethiopia, there are about 170 ophthalmologists, and around 60 cataract surgeons. Now, the type of surgery practiced in Ethiopia, the commonest one nowadays is SICS, is PCIL. But in some tertiary centers, we have FECO, just few people, not more than 10, 15, can do FECO now in the country, in just limited centers. I think there are some people who still practice, not many, standard CCE. And we no more do as ICC, just we may do it for subluxated or dislocated lens. So now let's go to the selection from manual small incision cataract surgery. Here, we don't have a fixed criteria, but we still prefer to do for people with poor vision because we don't have, we have many patients and we have to select. And we usually select for those with vision less than 660, and we prefer more mature cataracts still because there are the denser ones are better removed easily with our Simco, with our instruments. The less mature ones may have some difficulty. So we preparative care, we don't give routine investigations that we may just investigate for any indications. We do routinely blood pressure, IOP checking, and we do B scan only with indications. We don't do routinely. We give preparative medications when indicated. We do biometry, especially in tertiary eye care centers, but not all. There are places where we don't have biometry machines, and we may do just average IOL insertion. Our commonest anesthesia is retrobulbar. Occasionally, we may give subtenon or peribulbar as indication. We give GA for pediatric cataract at the center where we get GA. Scrubbing is done as usual with 10% povidone iodine and 5% povidone iodine we give. And the surgical procedure may be either superior or temporal approach, but the main approach is superior. We do temporal approach with indications like if the patient has glaucoma to preserve for later trap. Limbar peritomy is done as routinely. We may not have diathermy machine, so we still apply thermal cautery in many places, but in a few places we have diathermy machines. The scleral groove we do as you do, as we have seen before. It could be either front or partial thickness, 2 millimeter behind the limbus, 6 to 8 millimeter long. And now many of our cataracts have a dense presentation, and bronzescent cataracts are common. So we usually make our incision a little bit larger, 6 to 8 millimeter. And now, having practiced with very large nucleus, we noticed that we may not do 2 separate incisions as suggested by Dr. Pradeep, but it's good to know that. But we usually manage with just larger small incision up to 8 millimeter, even the large nucleus here. The scleral alternus is produced likewise. We do just half thickness and 1 to 2 millimeter into the clear cornea. Then we do asymmetry with keratom, we apply visco, and we do capsulotomy. Here, capsulotomy, we don't usually practice continuous curvilinear CCC here because our nucleus, usually our cataract is denser, brunescent, we don't have red reflex, and we don't have vision blue, trypan blue here, here right away. So even if we do have trypan blue, we preserve it for phaco. So we tend to do a can opener mainly and envelope. We only do CCC for very few where we can see red reflex. Otherwise, can opener technique is the common procedure here. For hydrolysis dissection, we use syringe and cannula. We use Synco cannula too. And to prolapse the nucleus in the anterior chamber, we use both Synco cannula or irrigation with cannula and saline. Now the nucleus delivery, we use irrigating vectors or hydrostatic pressure with Synco and visco with lens loop. We use all of our possible means to deliver it into the external part. And we remove the cortex with Synco, and we fill AC with visco, and then we apply PCL like PMMA. We don't have foldable NMA lens. We preserve that for phaco. And so we do visco washouts, check AC formation, and we give subcongenta and dexamethasone. And finally, we apply TTC and we apply patch. So we usually do overnight patch, and on the first post-op day, we check visual acuity, intraocular pressure, and we do slit lamp examination. And we prefer medications, ciprofloxacin and dexamethasone post-op. The routine is we give this 4 to 6 hours for 1 to 2 weeks, and we give dexamethasone, especially Maxidex. We prefer this brand because it's known to have a good potency. We give that for 4 to 6 weeks. And our common follow-up is 1 week and 4 to 6 week away. But there are many patients who even don't come the first week. They may come from far away, and the one contact maybe the only one we get the patient. So we try to manage as much as possible in the first contact, and we hope that they come for further follow-up, but many patients may not come. So we have many complications because we have in the next slide, let you know why the problems. There is intraoperative complications like PCT or zonal dialysis, and arteritis are very common because we do have late presentations. We have commonly undilated people. The iris of our patients is dark and not easily dilated, and because of that, the complications is not rare. I think it's more than we have many complications, and hemorrhage, especially for the beginners, buttonholing and premature entry is common. This may happen. And postoperatively transient IOP is very common. We may have straight keratopathy and corneal edema because of the large nucleus. It may rub the endothelium, especially for beginners. This is not unusual. We may have such complications, and rarely late complications are also there. Bullous keratopathy is not like as common as we expect. Usually corneal edema may resolve within few months, but the bullous keratopathy is becoming more common when we started learning PHECOS. Otherwise, it's not so common with the ICS. Other complications are also there, like any cataract surgeries. We have many challenges. One is we have the highest rate of pseudoexfoliation in the world. I think in the literature it says Scandinavian countries have the largest one, about 30%, but in Ethiopian studies, the pseudoexfoliation rate is about 40%. person. This is, I think, the highest in the world. We don't know why we have that. So our cataracts tend to be hard and fragile, and the people may not dilate easily. So we have many problems related with that, more than what you have, I think. Glaucoma is also common with cataract because the people come late. Pseudoproliferative glaucoma and other types of glaucoma associated with cataract are very common, and these patients tend to have poor visual outcome because they come very late. Dense cataract and hard cataract are here. I think, yeah, if somebody wants to learn how to manage difficult cataract surgeries, I think he has to come to Ethiopia. We have many challenges related to cataract surgeries here. And hypermature cataract is very common with weak zonules. And corneal changes are also very common here because we have high rate of trachoma. Traumatic scars are easy, many here. We may not see the anterior segment easily. Sometimes we may do just the surgery under poor illumination. We do have also lack of instruments and supplies, and we suffer from blunt conjunctival and venous scissors, blunt crescent, and non-functional forceps, and poorly aspirating cannula. It's very common in many places. So we do cataract surgery the hard way. We don't have vitrectors in many places. We are limited to only few tertiary centers. So managing difficult cataract surgeries, especially managing complicated surgeries, is difficult here. We don't have phenylephrine or tripambolus, so we couldn't do CCC for all patients. We may have poor functioning microscope in many places, so we don't have biometry machines for all. So we may tempted to do biometries only for few in the best centers. But even if you have biometry machines, there is also a lack of wide range of IOL power. Sometimes we may have the machine we do for every patient, but what the IOL we have maybe just the average power. Sometimes it may not give us a meaning to do biometry too in many places. Even we may not find it in the country. There is a difficulty of importing ophthalmic instruments and supplies easily. So we have many challenges regarding this. And we have visited Aravind Eye Hospital some years back, I think 10 years back, and I saw how committed your staffs, your supportive staffs are, and everybody does with I mean, just a great teamwork. So we may not find that in Ethiopia. Supportive staffs are small in number. They are not well trained, poorly trained, and commitment is also a problem here because they may not be well paid by the government and so on. So they also lack efficiency. Even there is less commitment by the government about eye care services. So maybe to alleviate these difficulties, there are some efforts being done by responsible sectors. Like there are more training centers to avail ophthalmologists. It has been just 10 years back now. 5 training centers are there. At least every year, like 30, 40 residents may be graduated, and the government is also showing some interest. It has set aside a special unit for the ophthalmology aspects in Ethiopia since a few years. So it has some improvement. There are dedicated international NGO partners working with us too, like Light for the World, HCP, Fred Wallace Foundation, and Oris International. And through these, we are getting some job trainings, we are getting some supplies, and also private sectors. Private sectors like that of Dr. Workayos here. We have a couple of them, especially in the main capital. They are helping people, and they are helping for quality cataract surgery by availing instruments and by availing supplies and giving service with affordable cost. But still, there is more to do. I hope you have some idea of our situation. Maybe you are welcome if you have any comments. Thank you so much.
Thank you, Dr. Jafar. I think that was a big eye opener for all of us. And your presentation was brilliant, the way it was constructed, going through Ethiopian culture and all the problems that you're facing. So we see that you have a huge demand for doing these SICS, and also all the challenges that you have extracurricularly, like instrumentation, other things that are not available. And what amazes us is like your selection criteria and how methodologically you go about the procedures. So the technique is the same. So I think there should be some way we can bridge the gap to get this forward. I think the best person to comment on this would be Dr. Venkatesh sir. So Venkatesh sir, with your experience and your comments on Jafar's presentation.
Jafar was closely watching the debate which happened after the first talk. Now, whether to do 2 millimeter or 7 or 9 millimeter or 10 millimeter. And then you come through these challenges now, which we have been hearing for some years. I mean, we are so closely working with Africa. I know Jeff Tabin just returned from Ethiopia, right? Trying to build hospitals. Now he's working in Philippines, doing a lot of high volume surgeries. I think the challenge is, sometimes we take it for granted. We have everything here now. We have beautiful Varnas, beautiful instruments, lenses, square edge PMMA lenses, which can prevent PCO in some of our SICS patients. But the other side is still having all these challenges, which Jafar beautifully highlighted. I think that's where the bigger picture is, or the bigger role is. Now, when David Chang talked about 5-minute $15 cure in Ben Kosh lecture in ACRS, all the eyes were wide open. Why is he talking about small incision when the whole world is behind phaco? I mean, he said, this is the answer. This is the answer for not this decade, for coming decades. Because the problem of blindness is so huge. We are dealing with the Californian cataracts now. I've seen many of the times Dr. Mohan Rajan showing us some cataract nigra, which are becoming quite rare these days. We are doing 6/9, 6/12, 6/6 clear lens extractions. But there is another group of people, whether they are in India or outside, with a huge backlog of advanced cataracts, the browns, the blacks, they are so huge with the corneal opacities because of trachoma, pseudo exfoliations with small pupils. I think the way to go will be small incision. But we need to look for ideas beyond this. How do we make it still more simpler for them? How do we make it still more uncomplicated? They should never get a vitreous to search for a vitrectomy. Can the knives be sharpened at the end of the day? I've seen Albert, our Henning, who came up with the Fushuk technique. At the end of the day, the surgeons have to sharp their crescents and keratomes. Then only they can leave. They had a system like that, so that you can't say my knife is blunt, my crescent is blunt. And he started using the diamond knives, which he used for 100,000, 200,000 Cs. Only thing is you have to keep it carefully. That's the only message he gave me. Venki, we have to keep this diamond knife carefully. I've used for hundreds and thousands of cases. I mean, people have to look for those ideas and come up with things which are much more simpler. Even the basic instruments, what we are saying, is still not available in Africa, are still not consistently, that supply chain is not there. So we need to see how we can make it more simpler for them, more easy for them to do the training, so that we give a better results around the globe. That's the larger message. I'm not going into the technique and details. Yeah.
Thank you, sir. Totally agree. I think subsequent talks on RT and Nilupama will give you some new techniques of doing SICS and how things are changing. So hopefully it might be useful for them. Paneer Selvam, sir, any comments? Because you've also been to Africa and worked with them. So
the message was conveyed by Venkatesh. I agree with them. I have limited experience doing surgery in Africa. The conditions are different. We should appreciate that and then encourage them to come up. That's a really wonderful talk by Dr. Jafar. And I think it's time we move on to the next topic, Dr. Nilotma Kanjuri on.
Full marks to Nivian, full marks to Jafar. It was really an eye-opener for all of us. I think it's given us the reality situation.
So next we'll go on to Nilupatma Diore. So she is working in the Department of Pediatric Ophthalmology and Travestis, but she's also in charge for the training of the DNB students. I think that's where the passion of SICS comes into play day in and day out, when you'll have to teach new people on doing SICS and making sure they do it right, and also managing complications. And also she has various interests in doing the new types of SICS and how it can benefit us. So we're going to hear a very interesting talk by her. So over to you, Nilpam.
Thank you so much. I am extremely honored to be invited on this forum, that is Tamil Nadu Ophthalmological Society. But before I begin my talk, I would like to congratulate Dr. Zafar for the wonderful presentation. And I feel extremely humbled in front of you speaking on advanced technique of MSICS when you are actually struggling with the basics of SICS. I would like to offer my services, if any, that I could help you. Thank you so much. So before I begin, so today I will be speaking on Dr. Sahu's technique of advanced MSICS. I do not have any financial interest in this presentation. So my gratitude goes to my mentor, Dr. Harsha Bhattacharya sir, and I'm extremely honored by Dr. Amulya Sahu sir for teaching me this technique of 2 mm SICS with 2 back cuts. So as I begin, cataract is the leading cause of avoidable blindness worldwide, and small incision cataract surgery undoubtedly, undoubtedly is one of the most frequently performed surgical procedures. Since its first description by Blumenthal in 1992, manual small incision cataract surgery has evolved remarkably over the recent decades, with overall outcomes comparable to phacoemulsification in certain settings. So the significant modifications of this technique that has related either to the incision or the method of nucleus delivery through smaller and smaller incisions. The resultant high wound of the MSICS technique has enabled these modifications, both in the incision parameters to minimize the surgically induced astigmatism and also to improve the refractive results of the surgery. So the aim of the study that I took up was to discuss this technique, that is the 2 mm MSICS found incision with 1.5 mm back cuts on either side. The primary objective was to investigate the pre- and post-operative effect of this technique on corneal morphometric parameters, and also to assess the influence on wound integrity, intraoperative complications, and the learning curve on the BCVA. This is a prospective hospital-based interventional consecutive case series. And the instruments, I would like to introduce you to some of the modified instruments. One is the multi-jet cannula for tunnel and AC cleaning. We also have the single-jet cannula for hydrodissection as well as endothelium cleaning. The PC polisher, the dialer with 1 mm tip, flattened visco cannula, so that if we are using a 15-degree knife, we do not cause damage to the Descemet's membrane or Descemet's strip at the side ports. The vectis with 2.8 mm hanging edge, and the revolving axis marker if we wish to go ahead with the tip axis incision. So to begin with, a 2 mm frown incision is placed 1.5 mm behind the superior limbus, and then we place the back cut incisions on either sides of the frown. The external incision is then dissected forward to 1.5 mm into the cornea. This dissection is then carried along the scleral back incisions to create the pockets. It is important to remember that utmost care has to be taken to remain in the same plane of dissection. Then when we enter into the AC, we make a larger internal incision up to 6 mm. The nucleus is then meticulously cracked between the modified vectis and the tip of the visco cannula while continuously injecting the OVT. The visco cannula gently nudges away 1/2 of the nucleus, and the remaining fragment of the nucleus is taken out. Now you see that I have put in a 5.5 mm optic PMMA IOL into the bag. This is possible if we extend the back cuts on either ends by 2.5 to 3 mm, which will create a hypotenuse of around 3.2 to 4 mm. The creation of the back cuts and dissection of side ports creates a compressible floor for the tunnel, which actually creates a trapezium net and helps gliding out the nucleus. So I would also like to show this video by Dr. Sahu sir, who has cracked the nucleus in the back, and then you can take it out with the vectis. So you see in the second video, this is a very soft nucleus where the nucleus has been tried to crack with the Khan's chopper, and because the nucleus is very soft, in this instance we would not go ahead with the Sinskey or the dialer to bring out the nucleus into the AC, but we can deliver it with the help of the flat instrument or the iris repositor, and this nucleus is then glided out easily with the vectis. So moving on, we looked at the results and then we graded the nucleus with the help of the LOC system tree. Now, there were 21 males and 30 females in this study at the mean age of 63.75. The visual acuity had improved from the first post-operative day, and it improved to a logMAR mean of 0.007 at 6 weeks, equivalent to the Snellen's acuity of 6 partial. The mean spherical equivalent of the autorefractor measured astigmatic error changed marginally to 0.5 diopter from 0.44 diopter, translating to a mean change in astigmatism of 0.1 cylinder when the axis was ignored. Now, I would like to show you that this is the cylindrical axis in the 2 millimeter that we got, and this one in the 6 millimeter, that is 0.5. So this actually translated to 0.4 keratometric reading and 1.4 cylinder in the 6 millimeter group. The surgery induced a difference of about half a diopter when a pairwise correlation was done. And you see this is the preoperative this cylindrical value that we got from the biometry. That's 0.76 at 160 or 170 degrees, and which translated to 0.05 at the end of postoperative 6 weeks. However, we induced a 1 diopter cylinder in the 6 millimeter category, that is from 0.43 to 1.26. The endothelial cell count was also looked into, and we can see that the CV ratio in both the categories was maintained equally. The wound integrity can be assessed with ASOCT or with an UVM, and we see that the interface damage is less in 2 millimeter, as well as in other 6 millimeter also, it remains the same. Intra-op and post-operative complications happen. These are my initial 51 cases. So the most common intra-op complications that I faced was tunnel injury, because I was unable to go through the 2 millimeter in the beginning. Then I had a PCR in one of the cases because the vectis touched the PC, and I had not inflated the bag properly with the viscoelastic substance. There was an iododialysis. This was a superior iododialysis which occurred when I tried to pull in the nucleus with the vectis without giving the back cuts. There was a small subconjunctival hemorrhage in 5 of the cases, and corneal edema happened in 6 cases because while trying to fill in the visco along with cracking of the nucleus, it touched the corneal endothelium more. So to discuss, if in a 2 millimeter frown incision without back cuts, what happens is a non-compressible tunnel is created wherein the nuclear fragments has to be dragged towards the mouth of the funnel to be engaged. The vector forces are thereby directed towards the dome of the cornea, producing a purse string effect and thus causing more endothelial damage. So you see here, I have not given the back cuts and I am actually damaging more, causing more injury. So this is the purse string effect that had occurred. So this is an advanced technique, so therefore it definitely has a steeper learning curve. But what we feel is that with discipline, perseverance, and an open-minded approach, we can definitely have some gratifying results. So to conclude, Dr. Sahu's technique of microincision MSICS with back cuts is a refinement of the incision. It has, by limiting the size of the incision and causing astigmatic neutrality. Viscofragmentation helps in safer corneal endothelial protection. Foldable IOL as well as rigid PMMA IOL with 5.5 millimeter optic can be implanted by extension of the back cuts. And, however, the wound architecture is maintained when the back cuts are also increased. It is cost effective definitely from phaco. It has got a less carbon footprint and it is reproducible. This is, I am doing in an Ingenuity system. There is no time lag in this surgery, and I was able to complete the surgery equally with ease. So the surgical outcomes are definitely gratifying in patients who undergo SICS. And I would like to thank you for your patient hearing. Creativity is seeing the same thing, but thinking differently, as said by Dr. APJ Abdul Kalam. Thank you so much. These are my references.
Thank you, Dihuri. I think that was a wonderful presentation and how you have done the study to show how astigmatism lead is slightly better with the new technique. So I think first we'll take some opinions from Dr. Okayu. Dr. Okayu is here with us in the panel. So he's one of the chiefs in Ethiopia and he's one of the...
Stop sharing the screen.
Sorry?
Stop sharing the screen.
Yes, yes. Sorry.
Dr. Okayu, your comments on the presentation and this new technique about the 2 millimeter ICS with the back cuts?
Can you hear me?
Yeah, yeah. Your voice is muted.
How about now?
Yes,
Can
sir.
Can you hear me?
Yeah, now you can.
Yeah, first of all, I would like to thank you everybody for embracing us and be a part of this group. You know, this has been a wonderful opportunity for us, you know, to share whatever we have and learn. Know that most of you are authorities on the area of innovators and authorities on this manual smooth cataract surgery. So really, I would like to thank everyone. Particularly, I'd like to send my gratitude and appreciation to Dr. Nevian, you know, for the confidence and trust that you have, and also your assistance has been wonderful in getting us here. Yeah, as far as this small, 2mm incision, I would say it probably is coming close to kind of a micro-incisional level. It's really exciting to see that manual small incision cataract surgery is developing to this level. But still, considering our setting, our background, even if they are not that complicated, having those modified equipment, it's everything depends on it. The other challenge still we have back here is also, with foldable irons, we may make incision as small as possible. We may fracture or fragment and deliver the nucleus in a small amount. Still, this supply chain issue has been a very hindering thing this year. It's only 50 centers and a few institutions. We have the luxury of having this, foldable iron implantation. Otherwise, the listeners would, surgical outcome is basically close to aspired in Ethiopia, which is wonderful. So my take is that, maybe the smallest incisions that we can do back here into maybe if you have the gut is a 5mm, so which you can insert the hard iron with 6mm diameter with some maybe stretching risk. Otherwise, coming here and trying to join is that, to get ourselves all the basis and also to learn all the innovations and updates going around. That's what can I say as far as small incision is concerned. But the other thing, I would like to add also some point on Dr. Jaffar's, my colleagues talk about Ethiopia. Really, our problem is really more than what has been described. We just talk of a blindness rate of 1.6, but still there is a 3.7% of low vision visual impairment. So we have the two figures. It goes about 6% of our population has got some kind of visual improvement, either related with cataract or refractive error or trachoma. But still 50% is cataract, which is close to 3 million. And the backlog we have is nearly 2 million. And this is too much for ophthalmologists or cataract center, what we have, which is somewhere around 200. So basically, it's not only that our problem is compounded with this inequity, the maldistribution of professionals. For example, about 65% of our ophthalmologists are in the capital city, while 90% of our population are in the rural area. So even sometimes, the ophthalmologist to population ratio, just by dividing figure, they say that 1 to 1.5. No, that's not the reality. In most peripheral areas, there is one ophthalmologist maybe for 5 or 6 million people. So, and the quality of the surgeries that we do is not that encouraging. So it is of vital for us, kind of to join people like you have. You are doing a lot to innovate, to adopt this high volume, cost-effective procedure. So for us, adopting manual smooth incision cataract surgery is not just an option. It's a necessity. And also we have to catch up because I do believe that we have been lagging in so many ways. This technique is not beyond our reach, but at the same time, we are not catching up with development, with innovation and the modification that people are developing. So that's why I have been insisting with my friend, Dr. Nevian, that really we should include Ethiopia in the society. It's not only that, if you have to include Ethiopia, I have been insisting with him, we should start from the periphery. And that's why I first brought in Dr. Jafar, who used to be my former student. Now he's the head of one of the medical institutions where there is a residency program in ophthalmology. And we are trying to involve also those new skills. Because I do believe that, manual small incision cataract surgery, it shouldn't, the kind of attitude that I see in Ethiopia is that we have this attitude, one size can fit every case, where by doing a 7 to 8 millimeter, we tend to handle every case. But from that, people have been reading, the articles, innovation that people have made. I'm learning that manual small incision surgery has to be case-based. It has to be modified case by case. The way how we do wound construction, the way we plan how to manage the nucleus, the way how we do, the anterior capsular rexus, because as Dr. Jafar has mentioned, we are sticking to this can opener just simply because we don't have tape and blue. So we know that we have a very high complication rate. They just not having the trifamble should not stick us into something that's not productive. So the general belief is that I think through time and through subsequent webinars, I hope you will be teaching us a lot because our problem is so huge, so complicated, but we cannot sit down and complain, I think I do believe that manual small incision cataract surgery is not that far beyond our reach. But,
Thank you.
We should not we should team up with you guys. That's what can I say.
Thank you, Dr. Okayo. I think your point is well taken, and that's why I said this is just the start. So I think we'll move on to the next speaker, sir.
Yes, yes.
And so next we have a dynamic Dr. Aarti Hedda, who's a consultant anti-segment surgeon of the National Institute of Ophthalmology in Pune. But that's the only CV she gave. But then she's a very dynamic person and a young dynamic person as far as MSICS is concerned. Her presentation, she takes very active part in most of the state meetings, and then she also coordinates and does a lot of meetings, and also been very leadership qualities in forming new societies for MSICS. So I think, and she's also won a lot of awards and presented in international forums also in SICS. So looking forward to hearing from you, Aarti.
Yeah. Thank you so much. So I should say good afternoon and good morning both. So at the outset, I would like to thank Dr. Mohanrajan sir, Dr. Paneerselvan sir, and Dr. Nivian for this wonderful opportunity. I would like to thank Dr. Sahu sir and Dr. Buramani sir for allowing me to present this work on astigmatism. And I'm actually very glad to present because I'm presenting in front of TNOA, the state where I started my ophthalmology journey, and in front of Ethiopia, the continent where I have worked for 4 years. So I can definitely relate what Dr. Zafar and Dr. Warkayu has said, because I have been there for 4 years. So without further delay, we'll move on to the talk. Okay, so as we know now, the cataract surgery has now become a refractive surgery, and the biggest concern with SICS is surgically induced astigmatism. So I'll start with a scenario. This patient with pre-op astigmatism of 0.13 diopter underwent a small incision cataract surgery. So, post-operatively, the patient had astigmatism of just 0.17 diopter. So is it possible to not induce any astigmatism with SICS? So let's see. Let me show you another case with pre-existing astigmatism of 2 diopter who happened to be a VIP and wanted to get implanted with autofocus pro lens, which is a multifocal lens without any rings. Presently, they don't have any toric range of lenses. So other eye also had astigmatism of 2 diopter, and phacoemulsification was done elsewhere, and the patient had same astigmatism of 2 diopter postoperatively. So we decided to do SICS for this eye with the aim of reducing the pre-existing astigmatism of 2 diopter. So the patient underwent SICS, and postoperatively patient has astigmatism of just 0.43 diopters on topographer. Autorev showed the astigmatism of 0.25 diopter, and subjectively the patient was 6/9 with plano glass. So the published data shows that the biggest advantage of phaco over SICS is that the induced astigmatism is less. But there are no studies yet to say how SICS wound modification can lead to desirable results on astigmatism. So the principle is very simple. A straight incision leads to astigmatism of 1.25 to 1.5 diopter. When the incision is frowned, wherein the end of the incision goes away from the limbus, the astigmatism produced is just 0.75 diopters, indicating that the more curved the incision is, the less astigmatism it will induce. So this is how one can titrate the incision against the pre-existing astigmatism. So after doing so many surgeries in last 5 to 6 years, we found that a straight incision of 7 mm will induce astigmatism of 1.69, and it will keep on going down as the size of the incision is reduced. So if the incision is frowned 1, the induced astigmatism will be only 0.5 diopter, and as you go on making it more curved, it will induce less astigmatism. So if it is a perfect U-shaped incision, it will not induce any astigmatism. The temporal incisions are away from the optical axis, so they are not very strong in inducing or neutralizing the astigmatism. So a 7 mm temporal incision will induce astigmatism of just 1 diopter, and a 5 mm will induce astigmatism of 0.4 diopter. So if the temporal incisions are curved, then they have no effect on astigmatism. So a superinasal and superotemporal incision behave in between the superior and temporal incision. So accordingly, you need to calculate. To have a better effect of incision on a steep meridian, you must center your incision on the steep meridian, irrespective of the shape and the size of the meridian, so that the vector forces are acting equally from both the sides on steep meridian. The next question is where to sit for the surgery. Whatever may be the steep meridian, you will always get this half circle on both sides. So you can go inferotemporal or slightly superonasal. Operating from the nasal side may be a little difficult, but you can always fashion your incision on the steep axis. The surgically induced astigmatism software can be useful to calculate your own astigmatism. You can put one type of incision in one meridian to find out your average astigmatism. So we will go through a few more cases. This patient had pre-op astigmatism of 0.28 and the steep meridian is 100. So the incision was taken at 100 degree and it was extremely curved. So there was hardly any change in the astigmatism. In this case, left eye, the steep axis is at 40. The incision was slightly curved, then taken at the superotemporal axis, and it hardly changed the astigmatism. Next case is where the astigmatism is of 1 diopter and the steep axis is at 90. The incision taken was straight 6 mm and it had reduced the astigmatism. So this is another case of multifocal IOL wherein the astigmatism is of 1.62 diopter and the post-op astigmatism has become 0.29 diopter. So this is a very interesting case with astigmatism of 3.5 diopter, and the patient was not willing to go for a toric lens due to financial reasons. A large straight incision was taken and there was a significant reduction in astigmatism, and surgically induced astigmatism was almost 3 diopters. So her incision was almost 7.5 mm on the steep axis. This is another case wherein the pre-existing astigmatism was 3.3 diopter and the post-op astigmatism was just 0.5 diopter. So another case of multifocal wherein the pre-op astigmatism of 0.33 diopter was reduced to 0.3 diopter. So next is a patient who was doctor himself with pre-op astigmatism of 2 diopter and the steep meridian was at 170, who actually was posted for a multifocal IOL. So the incision was fashioned at superotemporal quadrant and the astigmatism was totally neutralized. So this is his incision in the left eye, 165 degree. And this is his refraction. So now we can stop calling it as surgically induced astigmatism and better call it as surgically corrected astigmatism. And the technique should be called as a customized incision cataract surgery instead of just SICS. So thank you very much. And I would like to just share here that ISM-SICS have chapters in 4 countries in Africa, Nigeria, Sierra Leone, Tanzania, and we are looking forward to forming a chapter in Ethiopia as well. Over to you, Dr. Nivian. Thank you so much.
Thank you, Aarti. I think it was like wonderful because I think initially when I also started, the only surgery where I don't see about astigmatism or small incision cataract surgery with the only aim of getting the nucleus out. But now the things have changed and you're showed how you can match up to phaco and actually correct astigmatism and not induce astigmatisms and the new terms that you've come up with. Brilliant. So Venkatesh sir, your takes on this, sir, on astigmatic simply neutral small incision cataract surgery.
Very good talk, Aarti.
Thank you, sir. Thank you so much.
Brilliant. I think the way to go is to train more people to do this way. Maybe instructional courses or symposiums like this, because that's one major issue which we always have. And we know more the complex or difficult the cataract is. The bigger the nucleus is, we tend to make bigger incisions, like the case which Pradeep also beautifully showed, the V-shaped incision. So how do we make incisions which are even not only they don't induce astigmatism, but they can also reverse the existing astigmatism. So some of the cases which they highlighted where even a toric lens was not available and an incision could kind of manage it. I'm sure we have to look like that. Now, being a cataract refractive surgery has highlighted, small incision surgeons also have to look like that, because people cannot use glasses. These are people who cannot even afford glasses, like the scenario which we are seeing in India and Ethiopia. So if we can neutralize so that his uncorrected vision is good, he's going to manage his daily activities. And even if you can make him little bit like the EDOF component, somewhere can we do something where they get a bifocal into their eye? They can do plumbing work, electrical work. They don't have to depend on a glass after their surgery. So we need to work like that. And I'm sure this should become a regular armamentarium in our practice. Yeah.
Thank you, sir. Mohan Rajan, sir, your takes, because I know as a excellent phaco surgeon, you correct astigmatism all the time.
I like the nice concept of Aarti, the CICS, and even Diori's presentation on 2 millimeter, the sub 2 millimeter. I think the way forward, I think they are trying to, as Amulya sir rightly said at the beginning of the session, that I think it's, no, you cannot say that no more it's the SICS is inferior to phaco. I think we can customize, we can improvise, and we can do whatever. I can utilize astigmatism, can still get away with a premium IOL like a foldable lens or whatever the patient wants, and get good results at the end of the day. And even for hard cataracts, I think you can get clear corneas consistently on day one, which is it's possible because of the improvisation and customization which has been done. Hats off to you, all of you, and for working. Taking this forward, and I am very glad that we had a complete session on SICS today, because lots of learning are there, and each and every speaker I think is really wonderful. Thank you very much, Nivian.
Thank you, sir. I think yes, for those who don't have the femto cataract like you, I think using multifocals and torics after SICS, I think is a possibility now.
Dr. Nivian, if you can ask Dr. Sahu.
Sahu sir, this thing. I was just about to come to that because both of you students of Sahu sir. Sahu sir, your comments?
Well, see, we are not inferior to phaco, and the world is waking up. And so yesterday I had a talk with Boris Melugin, and they are starting a chapter in Russia, and there is an invitation from Australia. They are starting a chapter there also. So the world is waking up, and we are preparing our stars to go out and teach SICS everywhere. So that is our goal is here to make masters of SICS and showcase them to the world. They will go out and teach. America is learning from us. So that is one of those things that table has turned. We are always look to the West for guidance. Now they have to look to us because we have that kind of expertise with us. and experience, and we are giving excellent results.
Yes.
Nilut Konna is doing so much of she is doing a comparison with PECO also. So that's something, you know. I think all the big guns like Mohan Rajans and other people, they should start their research with the SICS, and that it will be a very good. And there should not be a PECO surgeon, SICS. You are a master, then you must know everything.
Absolutely.
He's a complete cataract surgeon. That's all.
I fully agree with you, sir. I
That
think
point is well taken.
yes, yes,
Yeah, people come to you not for your machine. They come to you. They should come to you for you. And you can say, I do magic with my hand. So what is the problem? You pay this much I am going to charge you for my magic. They will pay. They don't mind. They want a good eyesight. That point was there. There's a machine-driven marketing, and that everybody want. I have this machine and this machine. That page is over now. So you become an artist, and before that is what I'm going to talk in. They have invited me into this. What is that?
AO.
Andhra. So there I'm going to tell them like SICS before the PECO there have been great surgeons, and they have been thrown into these things. And why not you become with your magician in your hand? So what is the harm? Why let the machine be there waiting as it is being waiting in my
wonderful concept, sir.
Your take home will increase, your blood pressure will become less, and your assistance level will come down. You can do magic sitting there, and as the age advances, you don't have to depend on machine. You just do magic with your hands.
And
so
it's
I think
good to know that you're teaching the youngsters, and these youngsters are actually speeding up the process, I would say.
we had an inherent inferiority complex feeling, and that now has to be said now. 70 years of feeling they have been fed to us that we are inferior. No, we are not. Okay.
Thank you, sir. Thanks
India is rising. India is rising, and
sir, Nivian, one small comment about Sahu, sir.
Yes, sir.
Sir, my salutations to you, because I've been watching you and learning from you for so many years now. Hats off to your persistence, your perseverance, your conviction. I think that is, leading all of us. You are leading all of us into the conviction that SICS is as good or even better than the fake. Really, hats off to you, sir. Thank you very much, sir.
Thank you so much.
Thank you, sir. Thank you very much. I think so far we have been concentrating on the wound construction, how to expand or how to minimize it. Now we go to the next important thing is the nucleus management, which is very vital, because how to take out the nucleus through a bigger incision or a smaller incision, how to manage the nucleus inside the eye. And for this, we invite Dr. Vivekanand, Chief of Cataract Services, Arvind Pondicherry, to give a talk on this. Dr. Vivek, over to you.
Good afternoon, everybody. I would like to thank Mohan Rajan sir, Nivian, Paneer Selvam sir for giving me this opportunity.
Welcome, Vivek.
Yes, good afternoon, sir. So nucleus management in manual small incision cataract surgery is what I'm going to talk about. So there are two components to it. One is the nucleus prolapse into the anterior chamber, and then the nucleus delivery from the eye. So the basic necessity to perform this step, you need to have an adequate capsulotomy. It could be a capsulorhexis. In case of a runaway rhexis, can opener is always best. And then proper technique for the proper type of cataract makes the prolapse easier and delivery of the nucleus smoother. So coming to the first part of the management, it is the nucleus prolapse. So in most of the immature cataracts where there is no posterior polar component, we do a hydroprolapse of the nucleus. In case of a weak bag or a fibrous capsule, very dense cataract, we do a large capsulorhexis and then do a Sinski prolapse. In case of mature cataracts where hydro is contraindicated, you can do a bimanual prolapse of the nucleus. And there are special situations like posterior polar cataract and Morgagnian cataract. So we'll be covering all of these. So hydrodissection was first explained by Howard in 1992. So the theory is placing the hydrocannula between the capsule and the cortex, and then injecting the balanced salt solution or ringer lactate to have a posterior cleaving of the fluid and bringing up the nucleus into the anterior chamber. So hydroprolapse. So the normal hydroprolapse is the AC is decompressed of viscoelastic. The fluid is injected at one or two sites till the prolapse of the nucleus happens. So the difference between phacoemulsification and here is there we do a hydro dissection of the nucleus where we wait till the fluid wave passes through the posterior pole and then we decompress the back. But here we should not decompress. Instead, we should wait for the nucleus to prolapse, provided the rhexis is adequate. So this is the normal hydroprolapse we do where the nucleus prolapses on one pole. So to lift the pole up, we inject viscoelastic below the prolapsed pole so that it levitates more into the anterior chamber and then the nucleus is wheeled up. And then the cortical cleaving hydrodissection, just to show an retroillumination, just go underneath the capsular margin. So I call this a clean hydrodissection. So what is a clean hydrodissection? So if you do a hydrodissection so perfectly, there will be no cortex in the bag as well. So let me show it in the next video. So make sure you do not disturb the underlying cortex. Find a spot where the capsule is properly visible. Go underneath the capsule, go a little bit towards the equator and inject slowly till the nucleus prolapses. Once the prolapse is done, go on to either side the equator at the angles, inject viscoelastic so that the prolapsed pole is more prolapsed. So when you do this without disturbing the cortex, underlying cortex, there will be no cortex to remove. So the next step will be probably PC polishing and placing the intraocular lens. If you spend an extra few seconds, extra 10 seconds in properly identifying the capsule, focusing on the capsule, make sure you do not move the cannula here and there. This can be achieved in at least 70% of the immature cataracts where the pupil is dilated and you have a better view of the anterior lens capsule. And then coming to the Sinskey prolapse. So mostly, most of the immature cataracts, we do a hydroprolapse. That is what I would recommend. But cataracts such as these, where the anterior lens capsule is totally fibrosed and the pupil is small, if you do a hydrodissection, capsular distension can happen and you can lose the nucleus into the vitreous cavity. It is better to use the Sinskey to wheel out the nucleus. Make sure to use a lot of viscoelastic so that you protect the endothelium as well as the posterior capsule. So this is a video by one of my colleagues, Pawan, where in this video you can see that the rhexis margin is clearly visible. So you can go underneath, make sure you're going underneath the nucleus, underneath the capsular margin to the equator, hook the equatorial hard part of the endonucleus, lift it so that one pole comes out, and then with the rotatory movements, wheel out the nucleus into the anterior chamber. And then coming to the bimanual prolapse, you can either use a cyclodialysis spatula or a hydrocannula and a Sinskey. You need two instruments. You need to use both your hands. The main reason for doing this is when the pupil is small in mature cataracts or when the zonules are very weak. This is a wonderful technique of safely bringing out the nucleus. So in cases like this in the video where you can see the ALC is fibrosed, the bag is very weak because of the heaviness of the nucleus. If we do a hydroprolapse, there's a chance we might lose the nucleus into the vitreous cavity. So the best way to do it is a bimanual prolapse. Hook out the nucleus to one side using a spatula on the other side. Once you go underneath the equator, then it is simple. Gently wheel out the remaining part of the nucleus slowly into the anterior chamber. Make sure that you use a lot of viscoelastic because your Sinskey is above the nucleus. With such a large nucleus in the anterior chamber, you do not want to touch the endothelium and damage it. So sometimes this might be a blind procedure if the pupil is a little smaller. So you have to make sure that your left hand instrument, the spatula or the hydro-visco cannula, goes underneath the rexus margin. Because if you don't go underneath the rexus margin, there is a chance you might hook out the entire bag. So while retracting the iris with your second instrument, make sure that you're going little deeper. You can disturb the superficial thin cortex over the mature cataract so that you do not go over the rexus margin and instead go below it. And gently, it can be wheeled out into the anterior chamber. So this is how a bimanual prolapse can be done safely. And then coming to the special cases such as Morgagnian cataract. So the problem in these cataracts is the underlying nucleus size is we do not know how much. Only after draining the cortical fluid will we have an idea of how big the nucleus is going to be. So I use a keratome to puncture. As soon as I do the keratome entry, I use the keratome to puncture the ALC, drain the fluid using by injecting BSS slowly, because if you aggressive or forceful injection cause an Argentina flag sign. And then using a cystitome, doing a rexus with cystitome is a little challenging. So move the nucleus to the site where your cystitome is so that there is an underlying support. You can use forceps as well. So what I prefer to do here is a hydroprolapse, hydrodissection, or is a little difficult. So when you do a hydrodissection in such cases, the nucleus is going to be, it will be rotating inside the bag instead of coming out. And hooking out also is a little bit risky because we do not know the status of the posterior capsule. So what I prefer to do is I depress the tunnel and squeeze the eye. So by shallowing the anterior chamber, the nucleus pops into the anterior chamber, and either using a vectus or viscodissection, depending upon your incision size, the nucleus can be delivered. So what I would recommend in Morgagnian cataract is squeezing the tunnel, collapsing the anterior chamber so that it pops into the anterior chamber, and then fill up the anterior chamber with viscoelastic and perform a nucleus delivery. I do not have a video of a posterior polar cataract in SICS. So in SICS, what I would do is I would do a hydrodelineation, debulk the endonucleus, and then do viscodissection on multiple sites, bring out the epinuclear bowl into the anterior chamber, and do a visco delivery of it. If there is a posterior capsular dehiscence, mostly if there is vitreous disturbance, do vitrectomy, place 3-piece in the sulcus. So the idea is to do a delineation, debulk the endonucleus, and do a viscodissection of the epinucleus so that nothing falls behind. One other way which is the MyLoop in managing when you want to, when astigmatism comes into play, you want to have a smaller incision. You can also use a MyLoop. It's a lot of practice is required. There is a bit of learning curve. So through a 3-4 mm incision, you can remove. But there's a lot of learning curve. You have to use the wet lab to really master this instrument and technique. And coming to nucleus delivery, the basic thing is, first requirement is the anterior chamber should be filled with OVD so that the posterior capsule, the bag is totally distended, it is totally inflated. And then the endothelium is also protected because the nucleus is there in the anterior chamber. Second step is to engage the nucleus in the tunnel. You should, this is where the role of the brittle suture comes into place. And it is a quite quick step because if you do this step a little slowly while using the vectus, if the viscoelastic comes out quickly and you're a little slow, the posterior capsule is going to come in contact with the vectus, or your iris can be engaged between the nucleus and the vectus, causing an iridodialysis. So this has to be done a little quick. So there are two types of nucleus delivery. You can use the visco delivery or the irrigating vectus. You can remove the nucleus in toto or perform a nucleus fracture like shown in the previous video, and then deliver it to the small tunnel. What I prefer to do mostly in immature cataracts is visco delivery of the nucleus. In really hard cataracts, I use an irrigating vectus for delivery. So visco delivery, make sure there's a lot of viscoelastic underneath and above. Then go to one corner, depress the tunnel, and inject viscoelastic so that the anterior chamber does not collapse. No, I use the visco cannula to prolapse and then depressing, being on one side. If you're going to be in the center, the nucleus is going to get stuck on your cannula and there won't be much movement. So make sure to be on either the left or right end of your tunnel so that you have a clean visco delivery. And vectis delivery, here the principles are, fill the anterior chamber tightly with viscoelastic, pull the rectus. When you depress the tunnel, make sure you have a lot of viscoelastic above and below the nucleus. Check the patency of the irrigating vectus. We prefer to use an irrigating vectus instead of a plain vectus. So just squirt a little bit of fluid and see if the vectus patency is right. Depress the tunnel so that the nucleus engages within the tunnel. Go underneath it and irrigate while coming out so that the anterior chamber does not collapse. It's a very quick step because if you don't do this quickly, there is a high chance that you will damage the posterior capsule or the iris. And then coming to the last part of nucleus management, sometimes what happens is the nucleus does not come out. Instead, it can go inside. This could be because of multiple reasons, like I said, small rexes, hard cataracts, and doing all that. So when the nucleus goes inside, do not try to, go fish for it. If there's a lot of vitreous loss, do vitrectomy. Sometimes while doing vitrectomy, the nucleus might bounce back. So always make sure to use one of your instrument, either the vitrectomy or the irrigating cannula to go underneath the prolapsing nucleus so that you can bring it out. If it has gone too deep, don't go fishing for it. Just leave it. If you have a good rexus margin, place a 3-piece intraocular lens in the sulcus, suture the tunnel and send it to the VR. So I would like to thank again for giving me this opportunity. Thank you very much.
Wonderful videos, Vivek, as usual.
Thank you, sir.
Very nice.
Excellent, Vivek. Yes, as we all know, Vivek is an excellent phaco and small incision surgeon, and he has done various teaching programs across the globe in small incision cataract surgery. So, any questions from the panel or?
I want to know, Nivian, I want to ask Vivek or other surgeons, why you people are not using AC maintainer?
Vivek?
Sir, we are. It is right, sir. But in case viscoelastic is difficult for the in some places if it is difficult to acquire viscoelastic or there is a shortage, we can use that. But visco definitely in very harder cataracts helps in protecting the endothelium as well as pushing the PC down while doing the nucleus delivery. So we recommend all our residents to do this instead of the AC maintain. Probably in softer cataracts it wouldn't be a problem, but harder cataracts, I think viscoelastic is a wonderful tool in doing a safe surgery.
And what do you do if you have a smaller rexus?
Sir, one thing is what we teach our residents is when you have a smaller rexus, do a double rexus. Do not proceed with the surgery or give radial cuts across 360 degree. At least give 4 to 8 cuts so that it acts like a can opener. It opens up like a flower so that there won't be any stress and posterior capsular distension can be avoided when we do that.
Vivek, is there any place where these radial cuts has to be placed? Otherwise, sometimes it can extend when you make the radial cuts.
The thing is radial cuts on all clock hours. That's what I would recommend. I wouldn't say one place have a radial cut or a few radial cuts. Do as much as possible so that it opens up nicely so that there is little stress on the bag. And it will act like it will act like a spring. It will open up, it will close. So that is much safer.
The problem is sometimes with the radial cut during hydrodissection, there can be there's a possibility that can rip through, go across the equator into the posterior capsule.
Yes, sir. Multiple radial cuts that it can because there are multiple weak areas on the rexus margin, so there won't be that much pressure on one particular radial cut. So it is better to do a bimanual in case of radial cut so that you do not put stress on the bag.
I think, sir, the bimanual technique of removing the nucleus was an excellent technique, even if you have a smaller rexus, isn't it?
Yes, when you don't have an intact rexus, when you have a weak bag, multiple radial cuts, the bimanual is a much safer option than doing a hydro procedure.
Wakayu?
Yeah, if I may jump in, with this Morganian cataract, what we usually do is canoplar kind of capsulotomy. The frequent challenge we have is, the multipuncturate, the cortex
Voice is not clear, sir.
Excuse me?
Your voice is not very clear.
You have to be a little louder.
How about now?
Better,
Yeah.
sir.
Yeah. My question is in Morgandian cataract, we use this canopler kind of capsulotomy, so they want to make, the first puncture, the cortex liquid material inside, and it disorients us, not to follow our capsulorhexis through and through. How you experience with that as long as Morgandian cataract is concerned?
Vivek got the question.
Yes.
Make the nick that liquefies.
So when you make a small nick, the fluid which comes out is going to be slow, and sometimes it can go for an Argentina flag sign. So what I prefer to do is, once the keratometry is done, using the same keratome, I give a puncture in the middle of the anterior lens capsule, so that you have a broad opening and the intralenticular pressure is reduced in a controlled manner. When you have a small nick, it is going to burst out. When you have a broad nick, it slowly comes out, so that there is no pressure on the walls of the capsular nick. Once all the fluid is drained by gently injecting BSS, you don't have to inject viscoelastic. If you inject viscoelastic, the cortical fluid stays back. So injecting BSS will slowly drain the fluid. Once the fluid is totally drained, fill the bag and the anterior chamber with viscoelastic. And the ideal instrument to do a capsulorhexis is using the capsulorhexis forceps. In case you don't have the forceps, what I would do is use the cystitome, but move the nucleus wherever your cystitome goes. If I'm doing if the rhexis is being done superiorly, I'll use the Sinski to pull the nucleus superiorly, so that there is an underlying hard surface and rhexis can be done. So best way is to drain the fluid, have an adequate rhexis, and then shallow the anterior chamber bag complex so that it pops out.
Thank you.
Excellent, Vivek. I think we can wash it away with the Simcoe cannula also.
Yes.
Today's videos. Paneerselvam sir, anything else?
Excellent presentations, very good. I think it's time we move on to the next speaker, Dr. Amrita Arun Pandyan on SICs in special situations. Yes. Dr. Amrita.
Yes, sir. Am I audible, sir?
Yeah.
Yes, Amrita.
Yeah. Good afternoon, everyone, and good morning to the Ethiopia panelists also, speakers also. And let us proceed into the presentation. So in this presentation, I would be sharing my experiences and some tips and pearls on operating on brown cataracts, hypermature cataracts, small pupil, speculitic glaucoma, and cataracts with pseudoexfoliation. Before going into the topic proper, I would like to emphasize on the fact that we have to individualize each patient. Each patient is different and each cataract is different, and we have to customize our procedure depending upon the cataract we operate on. So for this, we have to thoroughly examine the patient preoperatively in a slit lamp and plan the procedure preoperatively, and we should be ready for any complications that may follow. So the concerns in brown cataract we have are the larger size of the nucleus, a poor retroillumination, and a friable capsule. So we have to fashion our incision so that it is a larger incision, around 8 to 9 millimeter in size. It can be a little bit anteriorly placed than the regular incision, and also can be a less curvilinear than a regular SICS incision. The scleral pockets also should be adequate so that the manipulation and the delivery of the nucleus becomes smoother. So stain the capsule and achieve a bigger capsulorhexis. At the same time, be careful not to extend the rhexis margin towards the periphery. Gentle hydrodissection at multiple sites is given, and the nucleus can be prolapsed into the anterior chamber gently with a Sinski's hook. Be sure to go underneath the capsule and bring the equator of the lens to, the one pole of the nucleus into the anterior chamber and gently dilate out into the anterior chamber. During the nucleus delivery, inject adequate amount of viscoelastic beneath and above the nucleus. Apply the superior rectus, apply traction on the superior rectus muscle, and you have to use the smaller size rectus because already the nuclear volume will be larger, and it will be better if you use a smaller size rectus for nucleus delivery. And during during the cortex wash, be gentle on the posterior capsule, as it will be very friable, holding on to a larger nucleus. And after the cortex wash, you can proceed with the IOL implantation. A bimanual technique for nucleus delivery is also a safer procedure for brown cataracts without causing any stress to the zonular complex. After the hydrodissection, we need two instruments, either a cystitome and a Sinski's hook, or two Sinski's hook can also be used. After the hydrodissection, we have to move the nucleus gently with the dominant hand instrument to one side, so that one pole of the nucleus becomes exposed, and the Sinski's hook is used to, Sinski's hook on the non-dominant hand helps to prolapse out one end of the nucleus into the anterior chamber, while the other instrument dials it out, the other instrument supports it. Coming to small pupil, the incisions, the concerns we have in small pupil are how to achieve a larger size or an adequate sized capsular rhexis, and also how to prolapse the nucleus surpassing the rigid or a small pupil. So the incision size will depend upon the hardness of the cataract, and after making the tunnel, we may or may not stain the capsule depending upon the maturity of the cataract. When immature, we might not need a staining of the capsule also. And after the incision and staining of the capsule, we may adopt procedures which will help us to dilate the pupil. It may be a pharmacological method like intracameral mydriatic agents, or mechanical devices such as iris hooks, or Malyugin ring, or BHEX ring, and surgical techniques like multiple sphincterotomies or stretch pupilloplasty. In multiple sphincterotomies, be careful not to extend the sphincterotomy beyond the collarette of the iris. Just approximately 1 millimeter nix will do. And after, if you're not able to see the rhexis margin, try to extend the rhexis margin beyond the pupillary border, and this comes only with practice. So after hydrodissection, a bimanual technique of nucleus prolapse into the anterior chamber will be a safer option. And during cortex wash, the visibility of the cortex underneath the small pupil will be difficult. So we can initially aspirate a smaller cortical bit and follow the cortex which is present underneath the smaller pupil, so that we do not have any complication. Just to look for any remnant cortical bits, we can gently push the iris tissue with a Simcoe cannula to look for any residual cortex. Coming to hypermature cataracts, the concerns which we have with the hypermature cataracts are the liquefied cortex, smaller size of the nucleus, and a friability of the capsule. So after making the initial incision, we will have to stain the capsule. And if the liquefied cortex is more, it can impede with the visibility. So after making a capsular nick with a cystitome, we can either aspirate or wash out the liquefied cortex with a Simcoe cannula, or we can aspirate with the hydrocannula. Or when the liquefied cortex is very little or very small, of very small volume, we can gently push it out by injecting the visco cannula, visco into the anterior chamber. There may be sometimes associated sclerotic sites on the hypermature cataracts. It will be better if we avoid the sclerotic sites. And in case if we are not able to avoid the sclerotic sites, we'll have to cut the capsular margin with the 1-hour scissors. The cortex wash should be as gentle as possible. Leaving behind few cortical fibrils is also okay, because the capsule will be very friable in such cases. And if the capsule is too weak to hold a rigid lens, we can go for a 3-piece lens in the sulcus also. Coming to phacolytic glaucoma cases, these patients will have the concerns which exist in hypermetric cataracts. Additionally, there will be a raised intraocular pressure and corneal edema due to raised intraocular pressure. So to decrease the corneal edema, we might have to apply a drop of glycerine over the anesthetized cornea so that the cornea gets dehydrated. And there should be a slow decompression of the anterior chamber with a slow paracentesis, so that we don't have any intraoperative choroidal detachment or expulsive hemorrhage. And the rest of the steps will be similar to as operating in the hypermetric cataract. And the capsule will be so friable, we'll have to adopt to a 3-piece intraocular lens in the sulcus. Coming to pseudoexfoliation, cataracts with pseudoexfoliation. Sorry, I do not have a video on this. Cataracts with pseudoexfoliation, we will have to face challenges such as pre-existing corneal endotheliopathy and poor pupillary dilatation or a rigid pupil, and zonal instability, and secondary angles, narrow angles, and raised intraocular pressure. So we'll have to fashion our incision depending upon the hardness of the cataract, and methods for pupillary dilatation, as I explained earlier, can be undertaken and address the zonular instability. Zonular instability can be made out while doing our axis. We can identify the zonular instability while doing axis by observing whether the nucleus as such moves together along with the capsule while doing the axis. So if the zonular instability is there, address it as early as possible by inserting a capsular tension ring. And we must be careful by removing the cortex not to catch the capsular margin with the Simcoe cannula, because even a slightest of stress can cause a zonular dehiscence. In some cases, if there is a specific quadrant of zonular weakness or specific quadrant of zonular instability, we can place a 3-piece intraocular lens in the capsular bag so that the haptics are in place of aligned in the axis of the zonular instability. So the take-home message would be, in a brown cataract, we have to plan a larger incision, larger axis, and if the pupil is smaller, we may have to shift to a capsulotomy also. And in small pupil, we have to take steps for pupillary dilatation, do a careful cortex wash, and in hypermetric cataracts, rexis, we will have to do a rexis with the rexis forceps, because we will not have support from the underlying cortex or the epinucleus. And if the capsule is very weak, we have to place a 3-piece intraocular lens in the sulcus. In phacolytic glaucoma, additionally, we'll have to add preoperative glycerin if there is a corneal edema, and slow paracentesis to prevent any intraoperative complications. In a pseudoexfoliation case, we'll have to do a larger axis so that the nucleus prolapse will be easier, and also it will prevent from postoperative phimosis of the capsule. And we have to ensure zonular instability and insert an appropriate IOL based on the zonular stability. Thank you so much for the opportunity. I would welcome any questions now.
Thank you, Amrita. I think
very well done. Amrita.
Amazing. You made all the complicated surgeries look very simple. You just very smoothly. So Amrita is actually a consultant at Arasan Eye Hospital and also a training center. So any questions from anybody or any?
Wonderful videos, Amrita. I think.
I have a question, sir.
Complicated situations, huh?
In small pupils, can we also use the stretch pupilloplasty technique instead of sphincterotomies in SICS? Amrita? I think on video.
What about iris hooks? Can we use iris hooks?
Vivek, can we use iris?
I think definitely, sir. We can use iris hooks.
Yeah.
But only thing is, when we are making that superior iris hook, now wherever your tunnel is, you need to be careful. Sometimes you may involve the iris hook entry with the tunnel. So you need to be little careful there. And again, what I recommend normally and what I do is when I prolapse and deliver the nucleus, I remove the 2 iris hooks on the top or the superior and then leave the inferior one so that your delivery will become easy. Otherwise, the iris hook can entangle in your irrigating vectors or when you do visco delivery. So iris hook is a nice way to do. I've tried with rings. It's very difficult with rings, again to prolapse a nucleus and do, but iris hook is a way to go. But when you're talking about the stretch pupilloplasty, definitely it works wherever you need only a stretch to happen. But if you want to have a relaxation on your zonules, like pseudoexfoliation cases with rigid pupils, it's better to do a sphincterotomies. Multiple small sphincterotomies are very good. And following a sphincterotomy, if you stretch, even then it gives you a little bit bigger pupil. But doing in a small pupil, those rexes, I think it really needs some kind of a training and experience, and it comes with your years of experience to follow that track. But for youngsters, I think it would be better to do even a can opener in those cases, which makes the procedure much more simpler. For the question which previously our Ethiopian friend asked, I think in Tilganga, where they learned SICS, right? They do the linear capsulotomy in all these Morgagnian cataracts. It's like an envelope capsulotomy. And then like what Vivek described, once you decompress the chamber and you make the anterior chamber shallow, the nucleus would come out. So they do just a delivery with the same irrigating Simcoe. They have something called an irrigating Simcoe, which you use for irrigation as well as for removal of the nucleus. It's kind of corrugated on one surface. So that is another way to go if you are having Morgagnian cataracts in your practice, because I've seen people do only Morgagnian cataracts in their practice. Like 100 cataracts, 90 will be Morgagnian, 10 will be without liquid cortex. So in those cases, it's a linear capsulotomy, and then you take your Vanus two nicks, and then you connect it with your Simcoe itself nicely, like a partial capsular excess.
Thank you so much.
I think the can opener, I think, is very important. If you're going to do a can opener in SICS, make sure that your openings are very close to each other. This almost mimics like a capsular excess. If you have can opener and if you have too much of interval between the can opener, there can be tags. And if you have tags, you can pull the tags and anything can happen. So I think it's better to place just like the femto rexis, wherein this thing is there very, very close to each other. Spots are very close to each other. Similarly, you can make a can opener very, very close to each other. So that you'll be able to get a fairly okay margin there.
Correct. Manisalam, sir.
Yeah, it's a very good discussion. It's really wonderful, and I thank all the speakers for their excellent presentation, the panelists for their wonderful input. Really, and we come to know about the Ethiopian condition and where they have to go, and whatever that we can do to help them out. And I want Vivian to give you the concluding remarks. Over to you, Vivian.
Thank you, sir. So I think once again we have come to a conclusion of yet another chapter of TNOA. Shining.
Sorry, can I just
sure, Jafar,
question?
Sorry.
I forgot to ask Dr. Pradeep. Just the method you showed us for 2 SICS or the V-shaped one. I like that, and I think could we use that for combined cataract and glaucoma surgery? Because the center one has a larger flap. And I think do you have such experience? And I think it might be good for combined cataract and glaucoma surgery.
I think Pradeep is not there because I do glaucoma. I've done a lot of combines. I don't think I'll take up that technique because because the V can help you for the apex suture, but once you make a punch there, you break the valve on either side, and then it may become difficult for you to close the wound. So if you're doing a tunnel flap, that is a trap with a tunnel flap, it's good. It's better to have a straight or a curvilinear, not the double tunnel which Pradeep was showing.
Okay. Yeah. It's very difficult to have a formed chamber. You cannot, you have to put multiple sutures. It will not serve the purpose.
Okay, thank you.
Vivian?
Yes, sir. So just a word of thanks. So once again, I think we have come to the end of the session. It's been a wonderful learning session with lots of questions, fights. And at the end of the day, it is the learning So from beginners to advanced, we have covered the entire spectrum. So that's what made it interesting. And we had speakers from across the country and outside the country. So once again, I'd like to thank all the TNOA members and the office bearers who have been with us and initiating this program. Special thanks to Mohan Rajan sir, as RK sir has already told, to doing this program continuously in the year and not missed any month on month, to his great effort. And even though he's not feeling well, he still makes sure that he's there in every program and sits through the entire 2 hours. So thank you, sir. And special thanks to Pannirselvam sir, who was very particular in putting the topics in such a way that should interest everybody. And at the same time, it should cover from the basics till the advanced, so it is useful for everybody. So thank you, Pannirselvam sir, for this wonderful opportunity, and Manoj for coordinating the entire thing. The IT team, I think Sai is behind every IT thing, that it goes on perfectly well without any confusion as far as IT is concerned. So thanks to Sai, and last not the least, all the speakers, Aarti, Dhonari, Vivek, Jafar, Pradeep Mohan sir, and all the panelists for being with us, Venkatesh sir, Sahu sir, and everybody for making this event a great success. Thank you once again for all.
Thank you so much, everyone. Mohan Rajan sir, I missed your jokes today. You did not crack many jokes. I was looking forward to them.
I think we should.
SICS has silenced him.
You can make any serious thing funny. I can get on that.
Because I'm not keeping. I'm running high temperature. Again, last week I'm not keeping well. So
no worries. Another session for your jokes.
Definitely.
Thank you, sir.
Thanks a lot. Thank you very much.
Thank you all.
Thank you.
Next session garland irukadilla sir.
July end varaikkum August first week da avla late kuduka maata Ramakrishan adha innொரு garland vechita Ramakrishan already created that I'll continue to use the garland. He said okay, no problem.
கற்பனை பண்ணிட்டு இருக்கோம் பாக்குறோம்.
Without garland I cannot breathe now.
Mohan sir, I forgot also a special thanks for my friend Wakayu, because I met him in Ethiopia. I think he's taken a lot of efforts in talking about this there and trying to be a part of our session.
Beautiful.
And they are actually planning to come down to Chennai during the IRSI time and sit us and have a talk.
Yeah. We meet up with them, Jafar and okay. Thank you very much.
Thank you for initiating the entire and being a part of it.
No.
Thank you.
As a society, you can see how to help them. No, as in training, in people going there and helping them. Because it's not going to help for somebody like Aarti staying for 4 years. We need to help them to do the fishing on their own. Now, sometimes we can parachute and help, but how do we do long term? As a society, you can see how we can do a long term support to a country. Now, you can always tomorrow say TNOA was able to do this in Ethiopia.
Yeah, definitely. Actually, our long-term plan is really to be a part of you, so that we can adopt most of the innovation and the update you people are making, because our situation is grave. So we need international partners, to fight to win our fight. So we are really excited with the prospect of working with you guys. So our long-term plan is really opening the chapter, Ethiopian chapter. So I think we will work hard towards that, and we really need your assistance.
Thank you, Venkatesh sir. Thank you, Wakayu, for
I think Nivian will take this opportunity.
Yes, sir. I think what Venkatesh sir
on behalf of the TNOA, I think we should pledge our support to Ethiopia, and as far as the training for the SICS technique is concerned. I'm sure the incoming president, Dr.
Definitely we will do it. Yeah, we will do it. Yeah.
Yes, sir. Yes.
Yeah.
No, because we know the know-how, we have the trade support, and also the kind of training support which we have. So if you can combine all three, Aurolab, Appasamy, TNOA skills,
absolutely.
You can
bring everybody together.
Yeah, limitations which they highlighted.
I operated twice.
I'm coming to India this coming July to attend the intraocular implant and refractive society meeting. Maybe I will meet you, some of you personally, have further discussion.
Yes, sir.
Sure.
Wakayu and Dr. Jafar. No, I've operated, come to Malawi. Twice I've operated through the Rotary, 2002 and 2004. We have done a huge number of cases there. And at that time it was ECC. We did many of them on ECC. And it was a great experience for all of us. But as Venkatesh rightly said, I think we should keep train you instead of getting somebody there and on a temporary basis. We should train you permanently so that it will be a long-term sustainability of this project. And TNOA will support you. We'll meet you during the IARSI. Me and Nivian and Dr. Sago also will be there. Everybody will be there. We'll meet you during the IARSI and we'll take it forward.
Sure.
Thank you so much.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, Mohan.
Thank you, Paneer, sir.
Thank you. Thank you.
Thank you so much.
Thank you.